many of you already met me, and for some of you this will be review, and for some of you this will be new information. So basically what they wanted us to talk about, what they asked me to talk about were some of the infusions and treatments that patients go, and what are some of the risks and the benefits for those treatments, and how are those products safe that we're giving to patients. So basically, they've already covered, we're talking about the autoimmune neurological diseases. So an autoimmune disease is basically when the immune system goes awry and it starts to attack parts of the body, and when you're talking about neuromuscular, that means your nerves. So that's your sensation and your ability to move, and your muscles. And also where the muscles and the nerves communicate together, as in some of the myasthenic patients. So, as they said, treatments for autoimmune disorders usually are one of those basic treatments, which are steroids, immunosuppressive medications, plasmapheresis, and immunoglobulins. Dr. Massey went over most of those. So for the steroids, they're suppressing your immune system, and it also helps with inflammation. With the immunosuppressive drugs, they're acting directly to try to stop the production of these negative antibodies. And then plasmapheresis and immunoglobulins kind of do the same kind of thing, but in a different way. And for some treatments, for some patients, one treatment is better. For some patients, the other treatment is better. So for plasmapheresis, if people haven't seen it, it basically almost looks like a machine, like a dialysis machine. And what they do is they take the blood out, and then they separate it, the plasma that has the antibodies, puts the rest of the blood back, and then will replace it either with albumin or saline or some other products. So for many patients, they consider this washing the blood, taking it out, cleaning it up, and replacing the other things. Now, in some studies, when they looked at Guillain-Barré, when they did plasmapheresis up against immunoglobulins, they were found to be equally effective. One wasn't better than the other. But the thing with plasmapheresis is that it is more difficult to give. You do need specially trained nurses, and not all centers or hospitals have a plasma exchange department. So we're going to talk a little bit more about immunoglobulins, because that's what I do in the day center. I give a lot of immunoglobulins to patients who have various different types of diseases. And should I see something? Okay. So for immunoglobulins, it's immunoglobulin G that we're using, because there's IG, IgA, IgM, and IgG, but the one we're giving is actually the IgG. And immunoglobulins are derived from purified human plasma. So sometimes when we're talking to patients, we'll say, your medication, but it's not a medication, it's a blood product, so what you're getting is actually a transfusion. Although it's different because it's a specific product of the blood that you're getting, not the blood in general. So it contains the antibody G, which aids in combating bacteria generally in the normal healthy body. Now, IVIGG comes from Hema-Quebec. They're responsible for the security and safety of all blood products. They're the only ones that will distribute these stable blood products, but they don't manufacture them. They're manufactured by specific companies. So what they've done is they've chosen the companies that they feel have a good reputation, have high standards of producing the products, and have been around for a long time. So the companies that we use here at the NHC are Gamma-Nex. That was probably the very first company that we ever used. But then as the need for immunoglobulins got bigger and bigger, they needed more and more distributors. So we have now we have Gamma-Nex, then we went to Gamma-Guard, and now we also have Privigen. Now as far as which product is given to the patient, that's the blood bank distributes the products, and they decide which of those products they'll give to patients. They all are very similar. There are some slight differences, and sometimes if a patient has a reaction to one product, because there might be a different stabilizer or something, then we at least have the option to try them on another product. So because it's a blood product, and you hear horrible things about blood and transmissions of pathogens and stuff, what we always tell the patients is that it's a little bit different, this product. Because when you look there, you'll see at the very beginning, when people sort of donate their blood, there's a higher chance that there may be a pathogen or something that gets into the bloodstream. But what the company does, and this slide is from Grifols, they were very nice, they gave me this slide. Other companies will have a similar type of process. It might be a little bit different, but the theory is the same. So in the beginning, you have the people that donate the blood, and then what they're going to do is they're going to check those donors, do like a history of that to make sure that they're the evolution too. So they do a donor screening to make sure that the person doesn't have any problems that may contribute to diseases or that they're not drug abusers or drug users or anything like that. And then they're going to test the blood for various certain types of diseases. And then it goes into an inventory management where it's held for a while. They'll do testing on it. And then they do a final viral removal and inactivation process, whereby they have a way that the covering in that of these different viruses and that gets sort of eroded away, so it's washed out. And it says here prion removal. Prions are what we in the public would think of as mad cow disease. So they do this extra step that's not always present in the other blood products that we may have to give, so that at the very end, the risks of that for the patients are actually much, much smaller than the risk of getting a regular blood transfusion. The other thing that they do to ensure the safety of anything that people get as a blood product is in Quebec, there has to be traceability. Every product that goes out has to be tracked to that individual person. What product did you get? What sequence number did you get? What serial number did you get? So that if there was any problems at all, they could track that specific bottle or product to that specific patient. So there's always a way to know who had it or who could be at risk if anything should happen. Now, how does it work? I think Dr. Massey did a good job at telling people how it works, but the thing is that it's not really 100% understood. But that it does go about by inhibiting and neutralizing the antibodies that are doing the attacks that he was showing you in the slides earlier. So they feel that it does this sort of inhibition and blocks these receptor sites and therefore neutralizes the negative antibodies. And when you do that, hopefully it gives your body a chance to recover and heal. But it doesn't, it's not a cure, like he said. It will help to control the symptoms, it will help to decrease some of the disabilities, but it's not necessarily a cure. So for many people who have had it, they know that it's given intravenously. The infusions can last anywhere from 2 to 6 hours, depending upon the dose that the doctor's ordered for you and the tolerance of the patients, because some people can tolerate it getting faster and other people will develop side effects. We always monitor the vital signs to make sure that some of the negative side effects don't occur and that the patient's tolerating it very well. And the rates of infusion are basically determined by the weight of the patient, so that there's estimates that you can do to find out what's the maximum rate for that particular patient, and also by the products, because each product has a different sort of theory of, or a different sort of parameters that they've tested as to what you should start at. So you usually start at a very small dose to ensure that there's no reactions, and then usually in a 3-step way, we'll go up to what the maximum dose is for that patient. We tend to be very conservative in our rates of infusion. I know in some centers they go much faster, but we found that there's less side effects and that many of the patients don't tolerate it at the upper ranges as well. So what are the side effects then? You always have to look at the side effects, because when you're looking at the risks and benefits, you don't want to have a treatment that will make you feel worse than the disease itself. So the side effects are usually quite transient. They're very mild, and they don't generally last very long. The most common side effect is headache, and it comes in about 40 to 60% of the people will have headaches. Fatigue is another one, generally for about a day to 2 days after the treatment. The patients are very, very tired, but then that seems to go away, and in about 48 hours, they're back to their baseline. There's nausea, chill, and fever with muscle aches, pains, and basically not all patients, but some people will go home and it's almost like they have like a flu-like symptom. They just feel achy and kind of miserable for about a day or 2. And then again, that's usually transient and goes away within a short while. Now for most of those types of side effects, usually Tylenol is enough for most patients. There are a few patients that have severe headaches, and so they will try to use some pre-medications before to try to take the edge off of them. Some people will start with Tylenol before the headaches will even start. And the other thing that they do a lot is we can play with the rates of the infusion, because sometimes slowing the rate of infusions will help with some of these side effects. Also, because the product is very thick and viscous, one of the things that we recommend is to stay well hydrated, because sometimes the hydration will help out with some of the side effects as well. It's been linked to a couple of different types of rashes and skin diseases. Most of these are annoying, but they don't necessitate stopping the treatments. Usually patients will be referred to the dermatology department, and they're able to sort of treat it with creams and that. I find people who have like psoriasis or those types of skin autoimmune disorders, sometimes it tends to flare up when they're on their immunoglobulins. The other thing that we've seen on a number of occasions is where people get extremely dry hands to the point that they're almost crack, and it's very itchy and it's painful. And the dermatologist usually will treat the patients with some creams and lanolins and some other types of treatments, and generally it goes away and the patients do quite well with those types of side effects. Now, the more rare side effects are also the more serious side effects. One of the things that can happen is severe allergic reactions, and that's with any medication, anything you take or put into your body, there's always a chance to have an allergic reaction. Now today, in the 15 years that I've been giving it, I have never seen it, so I hope I'm not jinxing myself. The majority of the allergic reactions that we have seen tend to be more hives. The person will start to get itchy, they'll start to develop some hives. Sometimes they feel cold and get very, very shaky. And then we treat them with a little bit of antihistamines and Benadryl and a little bit of steroids, and generally it goes away within about 20-30 minutes. The infusion is stopped, and then they could they go home, and usually the allergy doesn't reoccur after they've left the hospital. With these minor allergies, there's a couple of things that could be done. They could either try a different product to see if there's some sort of stabilizer that you're allergic to in the product, or sometimes they could give you pre-medications to prevent those allergic reactions from happening. Sometimes what they do is they just give you the same product, and the next time no reaction happens at all, because it's human donors and each product can be slightly different. So I've seen patients where they have an allergic reaction to one batch of the product, but then when the batch gets changed over, the next time they have it, they're perfectly fine. So together with blood banks and physicians, we decide what's the best way to respond to the type of reaction that the patient has had. Only rarely have patients had to be taken off of it. There's some cases where patients have developed very severe pneumonias, where it's almost like the IgG coats the red blood cells, and they see them as a foreign attack, and they start to lyse them. I've only ever seen this with one of our patients, but it's a very severe reaction, and generally they end up back in the hospital. What would happen, it's like almost like having a bad reaction to blood product. Because your red blood cells start to break apart in that, the person gets very tired, they get dizzy, they feel unwell, they might get jaundice, and then they have to come back in. In those cases, may even require transfusions. There's been instances where there's been a thromboembolic events with IVIG, and that's because it's very viscous, and it's particularly more prevalent if you have any predispositions or comorbidities that would contribute to those types of problems already. And when you think of some of these disorders, the CIDPs and the different types of autoimmune disorders, often they come in the later decades in your life. Not all, but some. So you're already at an age where some of these comorbidities, or stroke and heart attacks, may already exist. So the FDA said that there was 1% of patients that were having these kinds of thromboembolic events, but they wanted the physicians to be aware of it. And so in all of the the material that's presented by any of the companies, this is mentioned. So this means that a small blood clot is formed. It could cause a heart attack, it could cause a stroke, or it can go to the lungs and cause a pulmonary embolus, or it can go down into your leg and cause a blood clot. So patients who have high cholesterol, people who are diabetic, people who are much more sedentary, some of these side effects may be a higher risk for them than other patients. It's the same with renal failure. There have been instances where people have developed acute renal failure. I've never seen any, but they are listed in the literature. And again, those are also for patients who have comorbidities, but it could happen with anybody. One of the things also is aseptic meningitis. Aseptic meningitis is basically, it's in the realm of the headaches, but it basically presents as if you have meningitis. So patients may feel drowsy, they may get neck stiffness, photophobia, lights bothering them, the same kind of symptoms you would get if you had a real meningitis. But in this case, it's not an infection that they have. It's basically, that's why we call it aseptic. It looks like meningitis, but there really isn't any microbe or virus or anything that is causing it. It's basically some of these cells that have gone in and caused an irritation. Once the treatment stops, generally it goes away and it doesn't cause any major problems. But you have to come to the hospital and be checked out because you have to make sure you don't have meningitis in that case. Because you can't just say, oh, those symptoms are just because of the product, because if it is meningitis, it's not something they can ignore. And we talked about transmissions of pathogens. The companies in that and the people who get all these blood products do as much as they can to make sure that that there are no pathogens in them. But as we know, when we read the news in that, there is always new bacteria and new microbes that are either mutating or that we're finding out about. So there still does exist a very minimal risk that something we don't know about or that we can't find out about could get into these products and cause a risk for the patients. So we always tell patients, when they're asking about the risks and benefits and what the dangers are, that this is a small danger. It's there, but it is small, as many of these are. So when the patients come and they have their treatments in that, they can, it varies with the patients as to how they respond. Some patients will respond quite quickly depending upon their illness, and other patients will take several treatments before they know if the treatment is successful or not. It doesn't treat everybody, but it does. Some patients with certain diseases do respond very well to it. It's a simple treatment to give, and patients can have these treatments closer to their home. So we've had some patients who have had to be out long term, where we've been able to set them up to have their infusions at a local hospital closer to their home. So we have some people who have had theirs in West Island and then followed by their doctors here. When they're looking at research, there have been a couple of studies where they tried to give IV IgG subcutaneously, and we met with a representative to sort of see about it. With the neuromuscular patients, so it's a little bit harder because the doses are really quite high, and so to be giving it subcutaneously is quite difficult. I know there are some people who are still trying that to see if people can get it in their homes subcutaneously, but it's much more difficult for patients when they're very high doses of medication, because the side effects and the work that it takes, the amount of time that it takes, is usually the patients, the one that we tried, found that it was just so much easier to come in and have somebody give it to you than doing it every day at home by themselves. But there are studies out there where people are traveling with patients who have various diseases, and it may be something that may be more, more of an option for people in the future, because it is hard for people when they have to come to a hospital all the time to have their treatments.
So we're going to probably have a study for subcutaneous immunoglobulins and CIDP in the next month.
Mm-hmm.
We're looking into that.
Yeah. I think that's the next thing, because that gives people the freedom to be able to move around and to carry on their workload and not be so tied to a hospital. So I think that's it for me. And thank you for your attention.